Good morning, dear students. Today is 13th of May. We should continue our lecture, and I want to introduce assistant of our department, Dr. Лидяев Яков Михайлович. Пожалуйста.
Good morning, dear students. Today we'll talk about the acute coronary syndrome. Acute coronary syndrome refers to a spectrum of clinical presentations ranging from those for ST segment elevation myocardial infarction, STMI, and to presentation found in non-ST segment elevation myocardial infarction, non-STMI, or in stable angina. In terms of pathology, acute coronary syndrome is almost always associated with rupture of atherosclerotic plaque and partial or complete thrombosis of the infarct-related artery. In some instances, however, the stable coronary artery disease may result in acute coronary syndrome and absence of plaque rupture and thrombosis, where physiologic stress, trauma, blood loss, anemia, infection, tachyarrhythmia increases demands in the heart. And diagnosis of acute myocardial infarction in this setting requires a finding of typical rise and fall of biochemical markers of myocardial necrosis, in addition to at least one of the following. So, ischemic symptoms, development of the pathologic waves, ischemic ST segment changes on electrocardiogram, or in the setting of the coronary intervention. And now the terms transmural, non-transmural myocardial infarction are no longer used because ECG findings in patients with this condition are not closely correlated with pathologic changes in the myocardium. But therefore, transmural infarct may occur in the absence of Q waves in ECGs, and Q wave myocardial infarctions may be subendocardial and noted on pathologic examination. And because of elevation on ST segment during acute coronary syndrome is correlated with coronary occlusion, and because it affects the choice of therapy, urgent perfusion, reperfusion therapy, acute coronary syndrome related myocardial infarction should be designated to STMI or non-STMI. That's all. And in addition to the underlying mechanism of ischemia is important when managing acute coronary syndrome. A visible predictor of demand is rate pressure product, which can be lowered by beta blockers and pain stress relievers, while supply may be improved by oxygen, adequate hematocrit, blood thinners, vasodilators, etc. Etiology. So acute coronary syndrome is caused primarily by atherosclerosis. Most cases of acute coronary syndrome occur from disruption of a previously non-severe lesion that was previously hemodynamically insignificant. The vulnerable plaque is typified by a large lipid pool, numerous inflammatory cells, and a thin fibrous cap. Elevated demand can produce acute coronary syndrome with the presence of high-grade fixed coronary obstruction due to increased myocardial oxygen and nutrition requirements, such as those resulting from exertion, emotional stress, or physiologic stress, or psychological stress. Acute coronary syndrome without elevation in demand requires a new impairment in supply, typically due to thrombosis and or plaque hemorrhage. The major trigger for coronary thrombosis is considered to be plaque rupture, caused by the dissolution of the fibrous cap, and the dissolution itself being the result of release of metalloproteinases or collagenases from activated inflammatory cells. And this event is followed by the platelet activation and aggregation activation of the coagulation pathway and vasoconstriction. This process culminates in coronary interluminal thrombosis and variable degrees of vascular occlusion. Distal embolization also may occur. The severity and duration of coronary arterial obstruction, the volume of myocardium affected, the level of demand on the heart, and ability of the rest of the heart compensate are major determinants of the patient's clinical presentation and outcome. Anemia, hypoxemia can precipitate myocardial ischemia, and the absence of severe reduction in coronary artery blood flow. A syndrome consisting of the chest pain, ischemic ST segment and T-wave changes, elevated levels of biomarkers of myocyte injury, and transient left ventricular apical ballooning has been shown acute in absence of clinical CAD and after emotional or physical stress. The etiology of this syndrome is not well understood, but is due to the rate to a surge of cortisol stress hormones and or high sensitivity to those hormones. History, so how to take the history of the disease. The severity and duration of coronary artery obstruction, the volume of myocardial affected, the level of demand, and the ability of the rest of the heart to compensate the major determinants of the patient clinical presentation outcome. A patient may present to the emergency department because of the change in pattern or severity of symptoms. Typically, angina is a symptom of myocardial ischemia that appears in circumstances in increased oxygen demand. It is usually described as a sensation of the chest pressure or heaviness that is reproduced by activities or conditions that increase myocardial oxygen demand. A new case of angina is more difficult to diagnose because symptoms are often vague and similar to those caused by the other conditions, for example, indigestion and anxiety. However, not all patients experience chest pain. They may present with only neck, jaw, ear, arm, or epigastric discomfort. Some patients, including some who are elderly or who have diabetes, present with no pain, complaining only of episodic shortness of breath, severe weakness, lightheadedness, diaphoresis, or nausea and vomiting. Elderly persons may also present with only altered mental status. Those with pre-existing altered mental status or dementia may have no recollection of recent symptoms and may have no complaints. In addition, evidence exists that women more often have coronary events without typical symptoms, which may explain the frequent failure of clinicians to initially diagnose acute coronary syndrome in women. A summary of patient complaints here's palpitations, pain is and which is usually described as pressure, squeezing, or a burning sensation across the pericardium, and may radiate to the neck, shoulder, jaw, back, upper abdomen, or either arm. Exertional dyspnea that resolves with the pain or rest. Diaphoresis from sympathetic discharge, nausea from vagal stimulation, and decreased exercise tolerance. Here is some clinical examples. So, as classification of the angina: stable angina, unstable angina, new onset exertional angina, and variant angina. So, stable angina involves episodic pain lasting from 5 to 15 minutes, is provoked by exertion, and is relieved by rest or nitroglycerin. In unstable angina, patients have increased risk for adverse cardiac events, such as myocardial infarction or death. Here is the pain lasting more than 15 minutes but less than 30 minutes, and also this pain has the increased intensivity with each attack, with each next attack. New onset exertional angina can occur at the rest and is of increasing frequency or duration, or is refractory to the nitroglycerin. And variant angina or Prince metal angina occurs primarily at rest, as triggered by the smoking, and is due to coronary weather spasm only, without, in most cases, without affecting with the coronary atherosclerosis. Physical examination of the patient with acute coronary syndrome. Physical examination results are frequently normal. If chest pain is ongoing, the patient will usually lie quietly in the bed and may appear anxious, diaphoretic, or pale. Physical findings can vary from normal to any of these presented. Hypotension. May indicate ventricular dysfunction due to the myocardial ischemia, infarction, or acute valvular dysfunction. Hypertension may precipitate angina or reflect elevated catecholamine levels due to the anxiety or to exogenous sympathetic stimulation. Can be diaphoresis, can be pulmonary edema or other signs of left heart failure. Extracardiac vascular disease presented may be jugular venous distension, cool, clammy skin, and diaphoresis in patients with cardiogenic shock. In addition, the third heart sound S3 may be presented as frequently and a fourth heart sound S4 exists. The latter is especially prevalent in patients with inferior wall ischemia and may be heard in patients with ischemia or systolic murmurs secondary to mitral regurgitation. Assisted murmur related to dynamic obstruction of the left ventricular outflow tract may also occur, and it is caused by hyperdynamic motion of the basal left ventricle myocardium and may be heard in patients with apical infarct. Any murmur may reflect papillary muscle dysfunction. Rails on pulmonary examination may suggest left ventricular dysfunction or mitral regurgitation. Patients present to the emergency department with chest pain who have a low short-term risk of a major adverse cardiac event must be identified to facilitate early discharge in order to avoid lengthy and costly hospital stays. Here is the results of the some science research. The ASPECT study tested a two-hour accelerated diagnostic protocol that included the use of structured presented probability scoring method, electrocardiography, and point-of-care biomarkers panel that included troponin, creatine kinase, MB, and myoglobin levels. And the study suggests that this accelerated diagnostic protocol can identify patients at low risk for short-term major adverse cardiac event who may be suitable for early discharge. Such an approach could be used and decrease the overall observations periods and admissions for chest pain and has a potential to affect health service delivery worldwide. Myocardial infarction. So now a little more wide about it. So, cardiovascular disease costs $12 million through the world each year, and particular concern of the projects from the World Health Federation, the burden of atherosclerotic cardiovascular disease in developing countries will increasingly become comparison with that seen in industrialized countries. Myocardial infarction, commonly known as a heart attack, is an irreversible necrosis of heart muscle secondary to prolonged ischemia. This usually results from imbalance in oxygen supply and demand of the heart, which is often caused by plaque rupture with thrombus formation in a coronary vessel, resulting in acute reduction of blood supply to a portion of the myocardium. Although the clinical presentation of patient is a key component in the overall evaluation of the patient with myocardial infarction, many events are either silent or are clinically unrecognized, evidencing that patients, families, and healthcare providers often do not recognize symptoms of myocardial infarction. Myocardial infarction is considered part of a spectrum referred to the acute coronary syndrome. And before we talk that, we divided them to the non-STMI and STMI types. Patients with ischemic discomfort may or may not have the ST segment or T wave changes denoted on the ECG. And usually ST elevations seen on the ECG reflect active or ongoing transmural myocardial injury. Without immediate reperfusion therapy, most persons with ST elevation myocardial infarction develop Q waves reflecting a dead zone of myocardium that has undergone irreversible damage and death. Those without ST elevations are diagnosed either with unstable angina or non-STMI, differentiated by the presence of cardiac enzymes. Both these conditions may or may not have changes on surface of ECG, including ST segment depression or T-wave morphological changes. Myocardial infarction may lead to impairment of systolic or diastolic function and to increased predisposition to arrhythmias and other long-term complications. Atherosclerosis is the disease primarily responsible for most acute coronary syndrome. Approximately 90% of myocardial infarctions result from an acute thrombus and that obstructs an atherosclerotic coronary artery. Plaque rupture and erosion are considered to the major triggers of coronary thrombosis. With the coronary vasculature, fluid dynamics and shear stress are implicated in the pathogenesis of the vulnerable plaque formation. And evidence indicates that in numerous cases, covered lesions are stenosis of less than 70% that are located proximally within the coronary tree. Coronary atherosclerosis is especially prominent near branching points of the vessels. Culprit lesions that are particularly prone to rupture are atheromas containing an abundant macrophages and a large lipid-rich core surrounded by the thin fibrous skin. We have the specific risk factors for the myocardial infarction. They divided to the non-modifiable and modifiable. Non-modifiable risk factors for the atherosclerosis: age, sex, family history of premature coronary heart disease, and male pattern baldness. Modifiable risk factors for atherosclerosis, so that we can modify by giving patients some prescriptions about them, some smoking or other tobacco use, diabetes mellitus, hypertension, hypercholesterolemia and hypertriglyceridemia, dyslipidemia, obesity, sedentary lifestyle or lack of exercise, and psychosocial stress. We will talk about non-atherosclerotic causes of myocardial infarctions. They include mostly following: coronary occlusion secondary to vasculitis, ventricular hypertrophy, coronary artery emboly, coronary trauma, primary coronary vasospasm. Can be also drug use, for example, cocaine, amphetamines, ephedrine, arteritis, coronary anomalies, factors that increase oxygen requirement, for example, heavy exertion, fever, hypothyroidism, factors that decrease oxygen delivery, such as hypoxemia or severe anemia, aortic dissection. How to take the history of the disease. The patient's history is critical in diagnosing myocardial infarction and sometimes may provide the only clues that lead to diagnosis in the initial phases of the patient presentation. Patient's typical myocardial infarction may have prodromal symptoms of fatigue, chest discomfort, or malaise in the days preceding the event. Alternatively, typical STMI may occur suddenly without any warning. In general, the onset is not directly associated with severe exertion, instead concomitant with exertion. The immediate risk of myocardial infarction increases for six-fold on average and as much as 34 percent for people. High index of suspicion should maintain of myocardial infarction, especially when elevating women, patients with diabetes, older patients, patients with dementia, patients with a history of heart failure, cocaine users, patients with hypercholesterolemia, patients with a positive family history for early coronary disease. A positive family history includes a first-degree male relative aged 45 years or younger, or any first-degree female relative aged 55 years or younger who experienced a myocardial infarction. Other symptoms of myocardial infarction include the anxiety, lightheadedness with or without syncope, cough, nausea with or without vomiting, diaphoresis, and wheezing. The patient may recall only an episode of indigestion as an indication of myocardial infarction. Other symptoms of myocardial Elder patients with pre-existing altered mental status or dementia may have no recollection of recent symptoms and may have no complaints whatever. And for many patients, the first manifestation of coronary artery disease is sudden death, likely more from malignant ventricular dysrhythmia. Physical examination findings for myocardial infarction can vary. One patient may be comfortable in bed with normal examination results, while another may be in severe pain with significant respiratory distress and need for ventilator support. Patients with ongoing symptoms usually lie quiet in bed and appear pale and diaphoretic. Hypertension may precipitate myocardial infarction, or it may reflect elevated catecholamine levels due to the anxiety, pain, or exogenous sympathomimetics. Hypertension may include ventricular dysfunction due to ischemia. Hypertension in the setting of myocardial infarction usually indicates a large infarct secondary to either decreased global cardiac contractility or right ventricular infarct. Acute valvular dysfunction may be present. Mitral regurgitation due to the papillary muscle ischemia or necrosis also may be present. Typical chest pain of acute myocardial infarction is intense and unremitting for 30-60 minutes. It is retrosternal and often radiates up to the neck, shoulder, and jaw and down to the ulnar aspect of the left arm. Chest pain is usually described as a substernal pressure sensation that also may be described as squeezing, aching, burning, or even sharp. In some patients, the symptom is epigastric with a feeling of indigestion or of fullness and gas. Atypical presentations are common and frequently lead to misdiagnosis. Moreover, any patients may present with atypical symptoms which are considered the anginal equivalent for the patient. A patient, for example, may present with abdominal discomfort or jaw pain as his or her anginal or myocardial infarction equivalent. An older patient may present with other mental status. Atypical chest pain is common, especially in older patients and the patients with diabetes. Women tend to present more commonly with atypical symptoms such as sharp pain, fatigue, weakness, and other non-specific complaints. Diaphoresis, weakness, a sense of impending doom, profound restlessness, confusion, pressing cold, hiccuping, nausea and vomiting, and palpitations also may be presented in the clinical picture of myocardial infarction. Nausea and abdominal pain are often present in effects involving the inferior or posterior wall. Decreased systolic ventricular performance may lead to impaired perfusion of vital organs and reflex-mediated compensatory responses, such as restlessness, impaired mentation, pallor, peripheral vasoconstriction and sweating, tachycardia, prerenal failure. By contrast, impaired left ventricular diastolic function leads to pulmonary vascular congestion with shortness of breath and tachypnea and pulmonary edema with orthopnea. Shortness of breath may be the patient's anginal equivalent or a symptom of heart failure. In an elderly person or a patient with diabetes, shortness of breath may be only complaint. In patients with acute inferior wall myocardial infarction with right ventricle involvement, distension of neck veins is commonly described as a sign of failure of the right ventricle. Impaired right ventricle diastolic function also leads to systemic venous hypertension, edema, and hepatomegaly with abdominal-jugular reflux, which may result in sudden response underfilling of the left ventricle and a concomitant reduction of cardiac output. Other patients and those with diabetes may have particularly subtle presentations and may complain of fatigue, syncope, and weakness. As many as half of myocardial infarctions are clinically silent and that they do not cause the classic symptoms described above. Myocardial infarction is clinically silent in 25% of elderly patients, population of 50% myocardial infarctions occurs. In such patients, the diagnosis is often established only retrospectively by applying electrocardiographic criteria or by scanning the patients by MRI. In clinical evaluation, ventricular aneurysm may be recognized later with symptoms and signs of heart failure, recurrent ventricular arrhythmia, or recurrent embolization. Vital signs in patients with myocardial infarction. The patient has a heart rate is often increased secondary to sympathetic adrenal discharge. The pulse may be regular because of ventricular ectopy. Bradyarrhythmias may be presented. An AV nodal block or infranodal block may be also evident. In general, the patient's blood pressure is initially elevated because of peripheral arterial vasoconstriction, resulting from an androgenic response to pain and ventricular dysfunction. However, with the right ventricular myocardial infarction or severe left ventricular dysfunction, hypotension is seen. The respiratory rate may be increased in response to pulmonary congestion or anxiety. Fever is usually presented within 24-48 hours with the temperature curve generally parallel to the time course of the elevations of creatinine kinase levels in the blood. Body temperature may occasionally exceed 39 degrees Celsius. Observation of the chest. Rales or wheezes may be auscultated. This occurs secondary to pulmonary venous hypertension, which is associated with extensive acute level ventricular myocardial infarction. Unilateral bilateral pleural effusions may be produced agaphony and the lung bases. On chest radiographs, they are evidenced by blunted costophrenic angles. On MRI, they are evidenced by the dependent fluid signal intensivity. Heart. On palpation, lateral displacement of the apical impulse dyskinesis, palpable S4 gallop or the soft S1 sound may be found. This indicates diminished contractility of the compromised left ventricle. Abdomen examination. Patients frequently develop tricuspid incompetence, and hepatojugular reflux may be elevated even when hepatomegaly is not marked. Extremities. Peripheral cyanosis, edema, pallor, diminished pulse volume, delayed rise and delayed capillary fill may indicate vasoconstriction, diminished cardiac output, and right ventricular dysfunction or failure. Pulse and neck vein patterns may reveal other associated abnormalities as previously talked. Dependent edema may be graded from 0 to 4 by assessing the depths of persistent pitting after tongue pressure as applied to the patient's inner shin for more than 10 seconds, or by elevating the lower back and the patient has his or her legs elevated. Diagnostic considerations. Epigastric or chest symptoms from myocardial ischemia may incorrectly be attributed to gastrointestinal source. Often, this occurs despite the presence of dyspnea or diaphoresis symptoms and are difficult to attribute the gastrointestinal system. Additionally, patients with myocardial ischemia may report relief or improving gastrointestinal remedies. Remember that even myocardial ischemia can worsen with recumbency because of an increase in venous return and temporary greater workload. Tenderness of the chest wall is reported in many as 5% patients. If no injury or event is definite that could have led to a soft tissue injury, clinicians should be reluctant to render a diagnosis of musculoskeletal chest pain. Younger patients are overly represented in cases of missed myocardial infarction. Most likely this is because of the inherent bias that this is the disease of those who are late, middle age and older. Approach each patient with chest symptoms as an individual who could have this disease. Unfortunately, in the series of missed myocardial infarctions, the failure to recognize systemic changes is frequent. The failure leads in particular must be scrutinized carefully for any evidence of ST segment elevation by using a straight edge across the TP segments. Non-ischemic causes of ST segment elevation include left ventricular pericarditis, ventricular paced arrhythmias, hypothermia, hyperkalemia, left ventricle aneurysms. And these non-ischemic causes may lead to the over-treatment. The diagnosis of myocardial infarction may be missed in the setting of a left bundle branch block, and this may be delays in a failure of administering thrombolytics. This is usually because of delay in ECG performance, interpretation, and decision making. It is also affected by the availability of thrombolytics in the emergency department. Here you see a general number of diagnoses. With that, we need to differentiate the myocardial infarction. You see here the angina pectoris, anxiety, asthma, depression, endocarditis, gastroenteritis, herpes zoster, hypertension, pancreatitis, different type of shock, radicular pain, pneumothorax, etc. What we need to do with the patient with myocardial infarction. So the objectives of laboratory testing and imaging include the following: to determine the presence or absence of myocardial infarction for diagnosis and differential diagnosis, point care testing and testing the central laboratory of cardiac markers. To characterize the locus, we need to characterize the locus and nature, STMI, non-STMI, and extent of myocardial infarction. To detect recurrent ischemia or myocardial infarction, we need to detect early and late complications of myocardial detection. We need to estimate the patient's prognosis. Laboratory evaluation is particularly helpful in the presence of comorbid conditions that may affect the patient's prognosis and influence his or her care. Such comorbidities include the diabetes, renal or hepatic failure, anemia, bleeding disorders, respiratory failure. We can produce a cardiac imaging. Here is but therefore it may help to define the anatomy and degree of myocardial perfusion abnormalities. In low-risk individuals in whom acute coronary syndrome is suspected and who do not have the serial ECG changes or positive serial cardiac biomarkers finding, the guidelines recommended some form of stress testing to help confirm the diagnosis and guide the therapy. In individuals with highly probable or confirmed acute coronary syndrome, consultation to a cardiologist is maybe. To do so, coronary angiography can be performed to definitely diagnose or rule out coronary artery disease. Based on the angiographic result and patient comorbidities, subsequent treatment recommendations can be made, which may include medical therapy, percutaneous coronary intervention, or coronary artery bypass surgery. Here is the main guidelines for unstable angina and non-STMI. STMI recommended. The patients with suspected myocardial infarction, cardiac biomarkers should be measured at presentation. And these guidelines also recommended a total turnaround time of less than 1 hour and preferably less than 30 minutes for cardiac biomarker measurements. Here is we talk about additional studies are needed to determine the relative analytic performance to different point of care testing, the size of troponins, creatine kinase, myocardial band, CPK, MB fraction, and myoglobin alone or in combination. If initial markers are negative and have been measured within the 6 hours of symptoms onset, the biomarker should be remeasured within 8 to 12 hours from symptom onset. Here is the picture with the multiplies over. Here is upper limit, and here you see the troponin changes, red line with the large myocardial infarction, myoglobin and creatine kinase in the form. You see the blue line, and green line is the level of troponin with small myocardial infarction, and you see most of them produced in during the first day after onset of acute myocardial infarction. Troponin levels is contractile protein that normally is not found in spectrum. Serum levels increase within 3-12 hours from the onset of the chest pain, peak at 24-48 hours, and return to the baseline over 5-14 days. Creatine kinase level Here is we talk about creatine kinase MB fraction, and serial measurements of creatine kinase MB as enzymes levels were previously the standard criterion for the diagnosis of the myocardial infarction. Increases within the 3-12 hours of the onset of chest pain, reach peak values within the 24 hours, and return to the baseline after 48-72 hours. Myoglobin level. Myoglobin levels are highly sensitive but not specific. They may be useful within the context of the other studies and in the early detection of myocardial infarction in the emergency department. About other significant laboratory studies, we can count the complete blood cell count, and here we can see the patient white blood cell count may be modestly elevated in the setting of myocardial infarction. Usually within 2 hours and peaks 2-4 days with predominance on polynuclear leukocytes. We can analyze the chemistry profile, the erythrocyte sedimentation, lactate dehydrogenase, blood oxygenation also. We can find out the hypoxemia may result from pulmonary congestion, atelectasis, or ventricular impairment. But normal clinical situation doesn't include impending respiratory failure. Lipid profile. This may be helpful if obtained upon presentation because levels can be changed 12-24 hours of an acute illness. Selective protein and other inflammation markers can be also measured, and it will be presented in elevated level in acute coronary syndrome. Electrocardiogram. Here is recommended by the most recent guidelines for the management of unstable angina and myocardial infarction. And patient active ongoing symptoms suggestive for an acute coronary syndrome should have early risk satisfaction by checking cardiac enzymes levels and undergoing 12-lead ECG within 10 minutes of presentation of the emergency department. For patients with ongoing symptoms, serial ECGs should be performed to look for dynamic changes in the ST segment. Recording an ECG during an episode of the presenting symptoms is valuable. Transient ST segment changes that develop during a symptomatic period and that resolve when the symptoms are strongly predictive of underlying coronary artery disease. Comparison with previous ECG is also very helpful. In the emergency setting, ECG is the most important emergency department diagnostic test for myocardial infarction. It may show changes during symptoms and in response to treatment confirm a cardiac passage for the symptoms. It also may demonstrate pre-exciting structure or ischemic heart disease. Abnormal ECG or one that remains unchanged from the baseline does not exclude the possibility that chest pain is ischemic in origin. The changes that may be seen during anginal episodes include the following: transient ST segment elevations, dynamic T-wave changes, inversions, normalizations, or hyperacute changes, ST depressions, maybe junctional, downsloping, or horizontal. In patients with transient ST segment elevations, consider left ventricle aneurysm, pericarditis, presmental angina, Wolff-Parkinson-White syndrome as a possible diagnosis. Fixed changes suggest acute myocardial infarction. When deep T-wave inversions are present, consider the possibility of central nervous system events and drug therapy with two-cyclic antidepressants or phenothiazines as the cause. This ECG is most important tool in the initial evaluation and triage of the patient in whom acute coronary syndrome is suspected. It is confirmatory of the diagnosis in approximately 80% of cases, and the electrocardiographic evidence of myocardial infarction is seen in the images below. So here, as you see, acute anterior myocardial infarction. You see the first first ST elevation in first main lead, you see the depression first in third main lead. Then you can see the very strong noticeable elevation of ST segment in V3, V4 and V5. Mhm. Here is the acute inferior myocardial infarction. If you will notice, here is in first main lead, here is the ST elevation, here is the ST depression. In third main lead we will see mirrored, so ST elevation and acute anterior myocardial infarction. Here is the ST depression. And again, in V2, V3, V4, V5, here we see ST depression. And if we compare it with the acute anterior myocardial infarction, here's everywhere we will see ST elevations and as the main signs. And here is the posterolateral myocardial infarction, the third form. You see there is no strict changes in ST in first, second, third lead, but we will see the depression in V1, V2 and V3, the thoracic leads, and also ST becoming with the point of ST becoming the point of the ST starting coming back to the isoline, and it also becomes the positive coming above isoline. So this is some most important thing about acute coronary syndrome and particularly about myocardial infarction. For today, that is over. Thank you very much. Goodbye.
Dear friends, we finish our lecture, and if you want, you can write your questions in our chat. I asked Dr. Ligaev wait a few minutes, and you should write, is it clear? Write that always clear. If you have any questions, write your questions. Dear friends who present on the lecture, write anything in our chat ВКонтакте. Is anything clear? Or if you have any question, write in our chat. Okay? Конечно, люди есть.
Ну, понятно. Ну, затишка плохая.
Звук идет хорошо, а видео что-то. Все, давай еще пару слов. Прощаться.
So, again, thank you very much. Be well. Good luck. Goodbye.